So without further ado,
well, Kathleen, I'll make sure I leave that $25 gift certificate in the Marcus in your mailbox.
Your card's in everybody's bag too. Yes.
Okay. And my email address is on my card, so if you have questions about the presentation or questions about the procedure or anything like that, feel free to contact me via email. I also want to note that I have no conflicts of interest. I don't own Novilase Corporation or have stock in it, and there is no stock yet, but in any case, I'm interested in this particular aspect of local treatment in the breast purely because I think it's going to be a useful modality in the future, so no conflicts of interest. I'm going to move through my slides pretty quickly because my bedtime is at 8 o'clock and I want to make sure we get done and I get home, otherwise I'll be even more cranky than normal tomorrow when I go to Alexian Brothers, and we have some of the OR nurses from Alexian Brothers here, which I'm glad to see. And they draw straws, and whoever gets the short straw has to work with me. Okay, so to understand and to think about where you're going, I think it's useful to look back. So if we look back and we go back to the early 1900s, we have William Halstead, and he's seeing women, young women, 30s and 40s, and they have large tumors and they have bulky axillary disease. And not a whole lot they're doing for these ladies at that time, but he develops this theory, which is, if I remove more and more of disease, if I get every cell, then we're going to have better outcomes, and maybe some of these women will survive. And because of the nature of the disease at the time, he did get better outcomes in terms of local control on the chest wall. But he did not improve survival one speck, and he was a bit frustrated by that. But that was his intent. And we'd like to think that, you got to go out there, you got to get every last cell, you got to, get rid of all the disease. And to some degree, we're still a little bit, married to this concept, even to this day, when in fact, it's really just not necessary. We need surgery to help with local control. There's no doubt about that. And there's no doubt that it doesn't contribute to survival. It's the systemic therapy, as you're all aware, that does that. And I should mention, kudos to all the nurse navigators are here, who are here, because if your intervention with that patient increases the probability that they're going to get their systemic therapy, which it does, you're actually, and don't tell this to anybody, but you're actually making a much better difference in their survival than I am by cutting something out of their breast. So I applaud you for what you do. Remember, it's critically important to improve survival that they get their systemic therapy, and you're going to help them to do that, all of them. So here's Halstead right here. This is me helping him. But these guys came along. This is Bernard Fisher. This is Umberto Veronese. He's Italian. So there's a lot of good Italians in the breast care field. And these guys, along with some other people, came up at the end of World War II with the thought that, hey, you know what? We think that breast cancer is a systemic disease from its origin, and if we start giving systemic therapies, hormonal therapy initially and chemotherapy, then we may improve survival. And in addition to that, we may be able to reel back our aggressive surgical procedures. And some of you, although I'm looking at this crowd, I kind of doubt it, some of you may remember what those women used to look like when they had radical mastectomies. They wanted to reel back from that and do more conservative surgery. And in fact, they started their trials in the late 70s, early 80s. Okay, I mean, we're talking 40 years ago now. And those trials then as they started reporting outcomes in the mid-80s and 90s, they showed without a shadow of a doubt, without any question, that lesser is just as good as more as relates to survival. And if you added radiation to lumpectomy, you got equal, for all practical purposes, equal results in terms of local recurrence. Now, I had a patient in my office today quoting me 1980 type figures for local recurrence that some physician told her. The fact is, when you add full-blown radiation or full-blown adjuvant treatment, which includes radiation, chemo, hormone therapy, we see local recurrence rates in the breast after lumpectomy that are on the order of 2 to 4%. Those are contemporary types of local recurrences, not the 12% or the 15% that we saw in the 80s when the use of adjuvant therapy, particularly hormone therapy, chemotherapy, and compliance with radiation therapy was less. So these are equivalent therapies in every respect, and they've always been equivalent. Even when there were greater differences in local recurrence, they've always been equivalent in terms of survival. We've seen also kind of a reeling back from axillary surgery. This was another kind of idea where, you know, you gotta go get those nodes, you gotta get a bunch of them, you gotta get every last cell out of those lymph nodes. And there's been a great debate over the years in terms of, is axillary lymph node surgery just there, is it just diagnostic? In other words, obtaining that important information that tells you this patient's higher risk? Or is it therapeutic? Is actually removing those lymph nodes that are positive out of the axilla in some way beneficial? And this debate went on and formed the basis of a lot of angst for once we started doing sentinel nodes back in the late 90s. Because we thought that, you know, if you leave tumor cells behind in a lymph node, then that patient's going to get an axillary recurrence or they're going to die from that disease. And the fact of the matter is there was never really any evidence to that effect when people receive appropriate adjuvant therapy. Again, the key is the adjuvant therapy, that they get the appropriate radiation, they get the appropriate hormone and chemotherapy. When you do that, it's clear that even if there are cells potentially left behind, or even microscopically positive nodes, that there's no recurrence in the axilla. And we see that even when we know that there's a false positive rate with sentinel node biopsy, which could be as high as 5 or 10%. We know there are instances in which sentinel node's negative and there's positive nodes left behind, but those patients, when they receive their adjuvant therapy, you don't see recurrences in the axilla. Now, some of you have been around a long time. How many axillary recurrences have you seen? Think about it. It's rare. And in published data, just in a series of patients with negative sentinel nodes, it's 1 in 4,000. Now, we know the false positive rate's much higher than 1 in 4,000, so if it was the same, you'd expect, you know, 5% of those people to have recurrence in the axilla. And it just doesn't happen, and the reason why is because of adjuvant therapy. So now we've reeled back axillary dissection to the point where even women with positive nodes, as we found in Z11, these women, if they receive proper adjuvant therapy, you don't have to worry about the fact that they may have other positive nodes. What's key here is you got to make sure they get it. And I'll tell these women, look, if you don't follow the plan, maybe it's better that we go back and remove some of your lymph nodes. You know, back in the bad old days, lymphedema rates 15 to 25%. You know, my experience, lymphedema after sentinel node procedure, and that's a cherry picking of lymph nodes, that's not an en-bloc dissection. And it doesn't matter whether you have 2 nodes or 5 nodes or 7 nodes. If you're going in there just delicately cherry picking them out of there, lymphedema rates are 1%. And I want you all to ask yourself, if the lymphedema risk is 1%, is it worth telling that woman she needs to have arm precautions? I just snuck in that little thing which has been bugging me. Next, what's coming? We're not going to do axillary surgery at all. There's going to be no need for it because there's no therapeutic value, really. And the diagnostic information we're going to obtain from genomics. And I will tell you that this is important because, and I'm sure there are some women who are going to need axillary staging, but overall, you're not going to have to do it in a large proportion of patients. And already we're doing this in elderly patients. But we're going to start reeling back even further because the detailed prognostic information, the treatment information, we're going to get from genomics and from other types of assays, and we're not going to need lymph nodes. And there'll be substitutes. And maybe if there's a question, we might put a needle in a node or those kind of things. But the era of axillary surgery, as we've all known it, is going to fade away, just like this procedure is, you know, pretty passé now. Not too many axillary dissections are necessary in the majority of people. So, does it make any sense to take a tumor and ablate it in your nice office procedure with a laser or some other means if you're going to have to take that patient to surgery and do a sentinel node biopsy on it? That's kind of, you know, what's the point? If you got to take them to surgery anyway, you know, the lumpectomy doesn't add that much. So for percutaneous ablation to work, this is going to have to move forward in parallel with that, where you don't really need to do the standard sentinel node or axillary type staging that we've done over the past few years. What we see contemporarily is smaller tumors. This is related to improved compliance with screening and improved screening modalities, digital tomosynthesis and others. Increased awareness. Women are very good at finding even smaller tumors in their breast. Tumors that are oftentimes not even seen on their recent mammogram. And I know you've seen plenty of women like that. We also have an aging baby boomer population. So we're going to see more cases of breast cancer each year. Not because there's a higher incidence, not because there's a higher number per 100,000, but because we have an aging population. So there are more women in the age groups where breast cancer occurs. About 80% of all breast cancers occur in women over the age of 50, as you're probably aware. We're also going to have an improved understanding of individual tumor biology and prognosis and predictive behavior through genomics. We've seen the beginning of that with Oncotype and Mammapren, and that science is just going to continue to move forward and progress and really make our ability to select women for specific treatments and targeted treatments much better. And we'll have to deliver some of the more noxious type systemic therapies to fewer women, which is obviously a good thing. Our principles of lumpectomy or conservative management of breast cancer have been the same for a long time. We know that as a criteria of adequacy of tumor removal, that clear margins is the #1 criteria. You got to have clear margins. There was a lot of debate in the past, well, should it be 2 millimeters or 1 millimeter or 5 millimeters, and does that make a difference? And for the most part, as was just recently released in a Society of Surgical Oncology guidelines, it doesn't make any difference for most now. What the size of the margin is, you just don't want tumor on ink, which was actually the definition of clear margins going back to Fisher and Veronese's time. So we kind of moved away from that, and now we've moved back to it. So that's the definition of a clear margin that we accept for most people. Now, please keep in mind that, you know, and again, I say this all the time to patients, and I know you all know this, but whatever rule I give you about margins or about breast cancer, I can show you someone who broke it. So, you know, individualization of care is, as you're aware, critically important. That's why the multidisciplinary conference is such a great tool in treatment planning. Historically, if you're doing breast conservation, you're going to evaluate the lymph nodes at the same time. And if you do breast conservation, if you want to get a recurrence rate that is on par with mastectomy, you have to give radiation, and you ought to give appropriate chemo and hormone therapy as necessary. And again, to move forward with percutaneous therapy into the future, that's going to require a significant change in mindset. We're not going to have margins. We're not going to evaluate lymph nodes in the standard way. We will likely want to still give, at least in the early phases, until we can select out who needs what better, we're going to want to give appropriate adjuvant radiation therapy, and obviously you're going to give appropriate systemic therapy to those who need it. What's so bad about lumpectomy? I mean, it's a pretty darn good procedure, especially when you add in some oncoplastic techniques and some other things that help minimize some of the deformities that you can see, like lower pole lesions and so forth. Most of our patients have a very satisfactory result from lumpectomy. Most of them will be satisfied with their outcome and not require, but there is on the order of 10-15%, or it's not an unsatisfactory result. And I might be able to make that a little bit smaller, again using oncoplastic techniques, but there's still a subset. But lumpectomy is an excellent procedure and an excellent way to obtain local control of the breast. The lumpectomy part of the procedure is typically not very painful. It's typically low morbidity, low risk of infection, low hematoma rate, generally very well tolerated. It's usually a quick procedure. You're working in skin and subcutaneous tissues, so it doesn't require a very deep level of anesthetic, and thus the anesthetic morbidity and mortality is exceedingly low. You can do these procedures in octogenarians without any problem. So what's so bad about it? Well, I mean, not a lot, but that doesn't mean we can't improve on it. And I would suggest to you that a 15-minute procedure in the office, which is, think of it like a needle biopsy, local anesthetic only, and if that local anesthetic is put in a sufficient amount and in the right places, they will be anesthetic. They won't feel a thing. That procedure takes 10 or 15 minutes, and you're done. Now, that would be, if that works, and you think about that experience versus having to go to the hospital, having an operation, having an incision, recovery from the anesthetic, that's going to be very compelling to most patients. And if we think about trying to reduce costs and healthcare reform, the cost will be like core biopsy compared to open biopsy, easily be 50% of the cost. So there's some clear advantages to trying to move lumpectomy forward. I want to remind you also that lumpectomy is not completely 100% cytoreductive. If lumpectomy got rid of every single tumor cell, there'd be no benefit from radiation therapy. You'd have a low local recurrence rate just from lumpectomy. So there's cells behind. And I can't tell you, I mean, it doesn't happen every month, but probably twice a year, where I'll do a lumpectomy and I'll get clear margins. But I'm looking at the specimen radiograph, or I'm feeling the thing, and I say, I don't like it, it's a little bit close to that one edge. And then I'll take a little more tissue on that one edge at that time, and I get the path report back, and I got clear margins on the lumpectomy, and there's a little DCIS in that edge, and that margin's clear. So you're leaving disease behind, even when you have clear margins. We know this for a fact because of the higher recurrence rate with lumpectomy alone. So I'm not sure that the goal of ablation is 100% cytoreduction. It's all about reducing the volume of that disease to a threshold below which radiation adjuvant treatment is going to deliver a low risk of recurrence in that 2, 3, 4% range, which we consider on par with mastectomy. But we do want to destroy tumor cells with ablation. We already have proven evidence that ablative techniques work. They're used in the liver. They've been used for benign breast lesions. They've been used for pulmonary lesions. So this ablation idea is not new. It's been around for actually a long time as relates to other organ systems. In terms of adequacy of tumor removal, we may, instead of measuring that microscopically, we may be able to measure that with imaging. And again, for this to work, that's going to have to be the case, because you're not going to go in and take out the tumor. You're going to have to image or do some tumor marker or something to help you assess, have I reduced this burden in the breast to a level that is sufficiently low that my other therapies will work. Or maybe I'll have a means of saying, yeah, I did get 100% cytoreduction. There's no need for adjuvant therapy. And you know, we have pretty amazing technology. You just saw the nice presentation by Dr. Mehta on 3D. You know, technology is just going to keep getting better all the time. MRIs, PEM, BSGI, these are all pretty impressive techniques, and they're likely to continue to improve and may have applications here. 3D ultrasound is another kind of interesting modality that's out there. And the use of some things we already have, like using Doppler flow with ultrasound has been looked at in terms of helping us to understand the risk of recurrence. When you do an ablation, it creates, and I'll show you this graphically, it creates a zone of cell destruction, so to speak, and cell death. And that zone can extend beyond that 1 or 2 centimeters surrounding where the primary tumor is, which is the focus of the radiation treatment. So it's conceivable that with an adequate ablation zone surrounding the primary tumor, you may be able to dispense with RT in some of these patients. And on top, overriding all of this is the use of genomics. I mean, it's clear that bad tumors are more likely to recur locally than good tumors. So if you characterize a tumor adequately, it may have features that tell you this tumor just doesn't really have much propensity for local recurrence after ablation or lumpectomy, and thus you may not need radiation. You may have different criteria in terms of the adequacy of the treatment of that tumor. So the general concepts we use relative to who are candidates for percutaneous techniques relate similarly to the types of criteria that we feel are generally more conservative. Smaller tumors, unifocal disease. You don't obviously want multicentric or multifocal disease. You have to be able to see it because you're going to, and see it well. You want to have good visualization of the lesion. Now, I've done all of these ablations with ultrasound, but they can be done stereotactically. They can be done with MRI guidance too. Although I think ultrasound is the best modality. As I've mentioned before, there's going to be high patient acceptance, and I think we've seen this in our trial as well. The treatment times vary. I think 20 to 40 minutes is probably a little bit of an overestimate. It's probably closer to 20 minutes on average. Excuse me. Reduced costs as I've managed. And there are some challenges in it. Frequently after an ablation, there's a palpable lesion there, even if there wasn't formally. And this makes people anxious and nervous. Even makes me a little anxious sometimes. But usually when you ultrasound that or you look at it with imaging, there's reassurance there. On the MRI, there's nothing enhancing. It's like a blank. On the ultrasound, there's no hypoechogenicity. It's just all actually hyperechogenic, and that's just the reaction from the ablation in the fatty tissue. But when that woman feels a lump there, she's well, what's going on there? She can be worried about that. And if you do an ablation and then you let it go, if we weren't excising it, which is what the trial is, as I'll show you, that lump can persist, and we know this from our benign disease trial. It can persist, several months. And so what's her comfort going to be continuing to feel that lump in her breast over time? I mean, that's something we're going to have to assess when we get to the next phase of the trial. The multidisciplinary approach, I'm preaching to the choir here, but it's absolutely essential. You got to work well with your colleagues when you're doing something like this, particularly in a trial setting, but moving forward, it's going to be really important working with the radiologist, your primary care physician, and your other docs, because she'll go to see her primary care doc and say, hey, I still feel that lump there, and you know what happens after that. Okay, how are we doing so far? It's 23 minutes. I'm doing pretty good. So I'll show you a little bit about the procedure. We place, and this is some of the original trial information. Dr. Dolot, who really is the inventor of this technique, and he was down at Rush, and he was also the guy who brought stereotactic biopsy from Sweden to the United States. I mean, he's an amazing person, and when I caught wind that he was doing this, I jumped on board immediately because of his vision and his expertise. And so he's the one who originally started all this, and this is now 12 years ago. There's been some other data done. This used MRI guided. But these were patients he just treated, and they all had tumors less than 2.3 centimeters. He had some failures, but this was the early development of the disease. This basically shows you how we do it. I'm sorry about the watermark in the middle, but that's because because I'm too cheap to buy expensive software. So the laser needle goes in there. We then put a temperature probe secondarily. Again, think about this like an ultrasound guided core needle biopsy. You turn the heat on and you're monitoring the temperature through this probe on your monitor. I'll show you another view of this. You cook it till you get the temperature readings above 60 degrees. That could take 5 minutes, that could take 20, 30 minutes. Once you've hit those marks on that scale, you know you've got adequate tumor ablation. So it's not really a complicated procedure. It does take the same skill that it takes to do an ultrasound guided core biopsy. I mean, you have to have that adeptness and that skill, which a lot of people already have. You know, it's not like you got to learn robotic surgery to bring this new technology to the fore, which is a steep learning curve and hugely difficult. This is the same skill set that you use for ultrasound guided core needle biopsy, and people all over the country are doing that all the time. So that's another thing I like about this is if it works well, as I believe it will we'll be able to bring that to, you know, the people, so to speak, without too much effort. So again, this will show you, you put your probes in. This probe you want kind of in the center of the tumor. This sits about anywhere from 7 to 11 millimeters away. Did I get that right? Yeah. So 7 to 11 millimeters away. Each one of these, T1, 2, 3, 4, 5, they correspond to T1, 2, 3, or 4, 5 here. So you're getting your temperature readings in different locations. The one danger here is that you're going to fry the skin. And so you got to be careful about the skin distance, and we monitor the skin temperature during the procedure. But this also helps you to monitor that as well to make sure you're not overheating anything. There's a third temperature register right at the tip of the probe. So you turn on the laser, and something should happen. So the heating starts. You see this temperature go up right away. That's the temperature here. And then as the thermal conduction occurs and you start getting heating of the surrounding tissue, you see the probe temperatures going up here. Once you get into that red line above 60 degrees, you know you've created basically an ablation, a zone of cell destruction, which is spherical in size of this nature. Excuse me.
What's the water?
Yeah.
It's not open.
I love to hear the sound of my own voice, so I talk all day long. You didn't drink out of this one before, did you? All right. So while that's going on, we can monitor the procedure in real time. So I can see the laser probe in real time going into the center of the tumor. When I turn, and unfortunately I don't have a good video to show you, but what you see once you turn that laser on is there's activity. It's like a little bubbling here at the tip of the probe, and this hypoechoic lesion then, after adequate time, becomes completely hyperechoic. I mean, it's basically vanishing and going away. Now the lesion's still there. This effect is just a result of the heating and the thermal effects, but it's a way that you can, in real time and visually, see what's going on, and that is just a nice adjunct measure in addition to what you're seeing on your screen and so forth. In addition, you know, we're monitoring the pain and level of discomfort. Sometimes, you know, they can get pain from nerve endings on the chest wall here, and again, like I said, you got to be careful of the skin. If the lesion is, you know, 4 or 5 millimeters from the skin at presentation, you know, that's going to be a little bit tricky. You got to be careful when you're measuring that distance too, because when you're pushing down with that ultrasound probe, you're compressing that distance. So I usually like to make that measurement myself or make that assessment myself before I'll say, oh, you can't have an ablation. It depends on really what that true distance is when there's not too much compression. This is just an example. I won't go through that, but this is in the trial, and I'll show you the schema of the trial. But what we're doing is we're measuring. We're using MRI both pre-treatment and post-treatment just prior to surgery. And what you see on the pre-treatment MRI is the typical thing. There's enhancement, a lot of enhancement around the little artifact created by the biopsy in the clip. But post-ablation, you see this little ring of, this is the ablation zone. You can actually see this little white ring that's created by the fat necrosis and the ablation in the zone where you've heated up the tissue. Here's the center, and there's no enhancement here, which means that if there's any disease left there, it's going to be minimal. If I saw a lot of enhancement, I'd be suspicious that there was inadequacy of the ablation. This is a gross specimen from our last patient, and this is very typical of what you see on the gross pathology. It's showing up real nice on my screen. I'm not so sure how good it's showing up on yours. But this is where the laser fiber was, and that was sitting right in the heart of the tumor. This is all dead stuff. This is cooked, and this is the rim, that same rim you saw on the MRI. So you can kind of correlate the imaging and the pathologic findings. Now this woman started with about a 10 millimeter tumor, and we did find a few millimeters of residual disease on her pathology, but for the most part, that tumor was gone. And, you know, honestly, I want to have 100% ablation. Every one of these I do, but I'm not really convinced that that's what's going to be necessary for this to be an adequate substitute for lumpectomy. Time will tell. This is just explaining the same thing. We see some very characteristic changes, and you can't see that very well here, but there are some cells you can look at and you just know they're dead. They're what are called ghost cells, and the pathologist can easily point this out to us. There are other areas where you're not so sure, and this is another area of investigation now currently where we're trying to figure out, because H&E does not necessarily predict viability. Just because you stain them on H&E doesn't mean they're going to survive or be viable or cause recurrence. So I'm not really sure when we see 2 or 3 millimeters of what is standard staining H&E cells that those cells are really viable or that they'll produce recurrence. Again, I think it's going to take the next steps in this trial and investigation to show that. But there are some pretty characteristic findings that confirm cell death, and we need to do a little more work in terms of on cells that are persistently staining in a standard way with H&E. Are there other stains or other immunohistochemistry tests that we can do that might correlate more strongly with viability? So those are two different things. So lastly, a little bit just about the trial. It's now 15 centers, 9 in the US, 3 in the UK, 3 in France. Still waiting for my trip to Paris to, then I'd have to say I had a conflict of interest after that. It's designed, the trial is specifically designed to measure the adequacy of the tumor ablation and to see how that correlates with our imaging findings. It's a treat and excise protocol, which means we treat them, a month later, we take them to surgery and we do the standard stuff. Lumpectomy, sentinel node, standard adjuvant therapy. Because you're introducing a month time into the thing, an extra MRI into your treatment scheme, not everybody is gung-ho about doing it. But I find that about 1 in every 30 patients that I see total, excuse me, signs up for it. Our criteria are fairly strict. You know, smaller tumors, no pure DCIS, no extensive DCIS with invasive disease, no lobulars, you know, no neoadjuvant, nothing over 20 millimeters. So that whittles your group down right away. And then, you know, when you approach people with the idea, some of them are not interested. Now, my last patient, she was telling me, oh, I'm allergic to everything, and I'm worried about anesthesia, and you know, all this stuff. And I said, well, okay, and we went over all that, and we started to talk about her surgery, and then I said, you know, There's this other thing I got to tell you about this clinical trial we're doing, and I know you're not going to be interested in it because I just got the sense that every little thing would bother her. And of course, she calls me the next day and says, "Hey, I'm interested in that clinical trial." So that just shows you how good I am at picking out who's going to do it and who's not. The target accrual for this part of the trial, which is this treat and excise segment, looking at adequacy of ablation, looking at correlation with the imaging, is target accrual is 60 patients. And now we have how many? 40?
38.
38 in these 14 centers total. So we're getting there. Almost there. And then the follow-up on that, the plan is, and correct me if I'm wrong, Valerie, but the plan is at that point, if we get approval to move forward, we'll move to a randomization. So that would be something like, okay, you're a candidate for this. We do the MR, we do the ablation, and then post-ablation, there's a randomization, flip of a coin, heads you get surgery, tails you don't. Is that correct?
Yeah, that's
More or less?
It's in works.
Okay. So at that point, I think it's going to be maybe a little bit easier to interest patients in doing it because there's now you have this potential option to avoid surgery. And it's really that type of trial that's going to answer the question, is it equivalent to lumpectomy or not? Can you get the same rate of local recurrence in these people that you can with lumpectomy? And again, the addition of standard adjuvant therapy will be important. So now we do a core biopsy, we do the standard stuff. I am not the world's biggest fan of MR. I use it very selectively, but if these people want to be in the trial, they're getting MRs. So if they get one anyway, then you're not adding a step here. If it's somebody I normally wouldn't do one in, I tell them, look, I wouldn't do an MR on you, but if you want to be in the trial, I got to do an MR here, and I'm going to do another one a month post-ablation. So you do all your standard stuff up front. After we've qualified them and they sign the consent, we do the laser ablation trial right in the office, local anesthesia, just like a core biopsy. A month later, when we set all this up, well in advance, because we need coordination with our radiology department, and they've done a great job of that. We do another MR ultrasound, that's color Doppler ultrasound, and standard ultrasound, physical exam. Then we do lumpectomy, sentinel node as we normally would. Some patients have elected to have mastectomy at that point. But most of them get lumpectomy. That provides a nice comparison then in terms of what is your experience with the laser, what's your experience with lumpectomy. And then standard follow-up treatment after that. So everything after this is the same as you would normally do, except we're doing our follow-ups and doing our due diligence in terms of measuring our outcomes. There's some other things out there. There was a cryoablation trial which started, I don't know, 5 years ago. I don't know what happened to this, but it's kind of fallen off the map. There's transcutaneous therapy, which is kind of cool. You don't pierce the skin. You put a high-frequency ultrasound transducer on the skin, or you use focused microwaves with MRI guidance. This is all, another step back in terms of, it's very early technology, but these are interesting things that may become modalities for ablating tumors down the road. And it's interesting stuff. There's a lot of references here if you're really interested in looking at some of that stuff. But like I said, this is all pretty early stuff, or pretty early in development. I think I've kind of hashed this through enough. And in summary, I'll just say that I believe that ablative techniques have incredible promise as a selective application for local control of breast cancer. The multidisciplinary collaborative setting it will be essential to implement these therapies down the road, but they can be implemented essentially by anybody who can pretty adequately perform an ultrasound-guided core biopsy. Maybe even radiologists. I hate to say that. Let me just say sonologist, okay? And I don't care if it's a radiologist or a surgeon, by sonologist. Anybody know what a sonologist is? That's, you know what the word for breast is in Spanish? Seno. So a sonologist is a breast specialist. And if you think I'm making that up, I recommend you Google it when you get home or on your iPhone. Larger tumors, you give neoadjuvant therapy. If there's anything left, you ablate it. Forget the surgery. A lot of those women will have a complete pathologic response, and a lot of those women will never need any kind of intervention. And we have to figure out who they are, because even women with complete pathologic responses can get local recurrences, but they happen at a really low frequency. And again, that's after surgical therapy. But you can bet that there's going to be some of those patients who we give neoadjuvant treatment to, both chemo and hormonal, who are going to get a complete response where we'll be able to show they don't need anything else done. Nothing. But some of them will, and some of them will have a little residual disease, and to zap that with a laser to improve your local control, I think is going to be a nice technique. And that's it. 40 minutes and 48 seconds. That's the first time I've done it. So do you have any questions? Yes?
How about pain after the procedure? What kind of pain control do you use?
I will tell you, the first couple of people, and really every patient, I go home that night and I'm thinking I'm going to get 100 phone calls. And I'm like sitting by the phone practically. Not one. Tylenol, Advil, nothing. So post-procedure pain has been really minimal, and I was, I'm looking at my experience in comparison to other people in our, 38 patients so far we've accrued, it's very similar.
And then for the excisional procedure, do you use ultrasound wire lobe, or?
I use ultrasound localization for 98% of
Okay.
my lumpectomies all the time. Any other questions, Stephanie?
Just to clarify, if they're non-palpable lesions, are all the non-palpables then become palpable, or there's just a chance?
There's a chance.
Okay.
It depends on the location of the lesion, the size of the breast, etc. I mean, if it's buried in a C or D size breast, they won't feel it.
It's probably like scar tissue, isn't that what it is, basically?
It's a
scarring up.
It's kind of like fat necrosis, is what it is. Yes?
How many patients have you done so far?
I've done 3 since July last year. And again, I got to see about 30 new diagnoses for every one.
After you went on for the excision, what is, when pathology gives you a report, is it just necrotic tissue, or are there viable tumor cells left, or?
So we think, in each of these cases, we think there's been some viable tumor cells left. There are cells that are left, and again, they're small volume, which stain normally on H&E.
Oh, you said that.
Now, do we really know they're viable? I don't know. If, let's say I did never excise that, and I gave them radiation and appropriate adjuvant therapy, would they get a local recurrence? We don't know. And really, the only way you're going to test that is by some randomization post-ablation. Again, I think when I first started doing this, I'm thinking, okay, I want to kill every cell. I'm thinking like Halstead back, 100 years ago. And I'm really not so sure that that's what is necessary for this to work. It would be a lot easier if we saw that in every patient. It would be a lot easier to convince people, but is that really necessary? I don't know. We'll find out one of these days. Anything else?
I was thinking when you said that the future way could possibly be just local anesthetic and like lobectomy in the office, would that be under ultrasound guided imaging?
What I'm referring to there is ablation. So, I mean, like I tell some people, you know, I could do your lumpectomy in your garage with 2 shots of whiskey, one for me and one for you. I mean, it's possible. I know people who've done, you know, breast biopsies in their office. I mean, you know, that's like Civil War surgery in my mind. And so the point of I was trying to make is, you know, ablation is a procedure you can do in the office with a local anesthetic, just like you do a core needle biopsy. Whereas lumpectomy, you got to do in the operating room. Typically with a general anesthetic, you're doing a sentinel node, and if you're just doing lumpectomy alone, there's been some evidence that says general anesthetic results in fewer positive margins, because you can imagine they're, you know, uncomfortable with the local sedation. I mean, bottom line is everybody who gets a lumpectomy is going to go to the operating room, and people who get ablation, you can do that in your office, straight local. No sedation, and they're comfortable, like they would be for a core biopsy, assuming you use good technique in terms of the local anesthesia.
So you don't worry about like the infiltrate from the liquid in the local vaporizing and affecting the temperature?
Well, that's a very good question. Actually, what we worry about there is the liquid, too much liquid being a heat sink, so you can't drive the temperature up high enough. And there's some ways around that. Put the local in, you wait a while, it gets absorbed. For some people, you just don't need that much local that it's going to act that way. Anything else?
I was just going to say, I think the most interesting part is how this can really affect neoadjuvant therapy. I mean, that'd be really interesting if that were part of the next part of the trial, is to see. Because I really think if you do neoadjuvant, because that seems to be the way that everything's going now, it's kind of swinging back to neoadjuvant, that using this in that setting would be really interesting to see. After neoadjuvant setting, then doing ablation. I mean, that'd be interesting if the clinical trial could go that way.
I agree with you. I mean, and one particular instance I'd like to use that in are some of these octogenarians that I'm giving neoadjuvant hormone therapy to, and they get a nice response, but then there's kind of a little bit left. I mean, I would love to plug a laser into that and zap it, and I got a feeling before too long we may be able to do that, but right now I can't offer any evidence to support that. And clearly I think neoadjuvant is how we're going to treat all breast cancer once we figure out, you know, the right targets and the right treatments. And there will be very few people left then who actually need anything done. If you can get PCR rates up to 70, 80, 90%, and identify subsets who don't need any local control in terms of surgery or ablation or whatever, or any adjuvant radiation therapy, I don't know. I mean, there's some trials set up now to randomize people with PCR to surgery versus no surgery. I know of a trial, NSABP trial, I think it is, that's being planned, and something similar for, and this is always a difficult topic, which is post-mastectomy radiation in women who've had positive nodes, pre-treatment, pre-neoadjuvant treatment. They get downstage to negative nodes, and the radiation doc still wants to give them radiation, and appropriately so until we get the right evidence. But there's another clinical trial being done there, which is going to look at radiation versus no radiation in people who downstage their nodes. So I think those are the kind of things that are coming out. It'll, you know, it's another couple sequences before you get to something like using ablation in neoadjuvant patients. Yes?
I just have one more quick comment. You should partner up with Laszlo Tavar, because, you know, he is so good about trying to find those small tumors that's causing so much controversy about we're over-treating everybody. And I still think if a woman finds out that there's something going on, no matter how small it is, she wants it treated. And wouldn't this be a great option to put it all together?
You shouldn't have asked me that question. You shouldn't have asked me that question.
Oh, really? Oh, okay.
That's a whole other talk, right there.
So
Yeah.
I want you to think about microcals versus tumors. Those are two different things. And pursuing microcals has given us a lot of DCIS. And it hasn't changed the number of, at least we believe, it hasn't changed the number of invasive cancers that we're seeing. See, the idea was, hey, we'll find all this pre-cancer and then we'll see less of the invasive cancer, right? Because you're nipping it in the bud. And it doesn't appear that that's happening. Now, we don't know for sure because we don't know what would have happened if we never did mammography, like we've been doing it since 1985. But there's been some reports published and some very smart people, you know, tons smarter than me, who have published this kind of information using computer models suggesting that even if we assume the best, there's not a concordant dip in the invasive disease. And I have some good articles on this, and you can look yourself. Her name is Laura Esserman, and she's at UCSF, and she's one of our thought leaders in breast disease and in the Society of Surgical Oncology. I mean, she's one of these top-level people, and this is, you know, I didn't dream up this stuff. She's the one who identified these concerns. So, you know, I'm concerned that our imaging is, you know, too good. It's showing us stuff that maybe we'd be better off not knowing about. And it's clear to me, absolutely crystal clear, that there's a real threat of overdiagnosis in elderly women, 70s, 80s, etc. There's no debate, no question there. Where I start to wonder and worry more is, you know, as you get younger. Because if you find significant proliferative change in a younger woman, that's more likely to result in an invasive cancer at some point. But again, you can't show it. I think the other thing is, because our treatment is better, the difference in survival between a woman who finds her own lump in her breast, which is going to be 2 centimeters or so, you know, she's paying attention. Now, these are women who are paying attention here, not somebody who's going to neglect something or something like that. But someone who's paying attention, most women, they find something in their breast, it's going to be 2.2 centimeters. And if you look at mammographically detected tumors, they're going to be 1.5, 1.7, something like that on average. The difference in survival between those two has gotten smaller and smaller and smaller because our treatments are better and better and better. So it's going to be really hard to show that finding a lesion on mammography that's invasive, forget about the microcals now, that's invasive, is going to deliver any better outcome than a woman just finding it herself if she's checking herself. That's what the Canadians are saying. Now, I'm not a big fan of Canadians either, but you know, nobody's got the answer, right? But you know, there's concerns there that I think we ought to pay attention to, and not just assume that, you know, we've had the answer all along and mammography's it, and biopsying every microcal you can see is the answer either. Because although it seems like you're doing a good thing, it's possible that you're not. Remember, every patient with DCIS, first of all, they have this diagnosis of cancer, and that's a burden for a person to carry around, and they carry it around their whole life. And then they get treated, and they get surgery, and they get radiation, and they're told to take medication. And it's possible, and you know, DCIS is a non-obligate precursor to cancer. Not all of them become invasive cancer, and maybe it's fewer than we thought. So are you really helping people when you're doing that? I mean, that's what I lose sleep over. In any case, all those answers will be figured out probably in the next 5 or 10 years. And I think, you know, things like genomics and genetics, that's, if you have kids and they're interested in medicine, that's where they should go. That's the field of the future, and that's going to bring us a lot of answers and make some of this stuff just a moot point. Better solutions for sure.
Thank you.
I told you shouldn't ask me.
I'd like to hear it.
All right, thank you.